Good evening, everyone. With 125 registered guests from over 20 countries, perhaps it's more appropriate to greet you with good morning or good day. I'm Art Kurz, the Chief Marketing Officer for the Lion's Eye Institute for Transplant and Research. Thank you all for joining us for the second in our webinar series as part of the Lion's Eye Institute's Surgeon Training Program. We are excited to host this webinar with our panel of experts, including Dr. Bert Knauf, Dr. Yassine Daoud, and Dr. Stephen Kane. You will hear from each of them as they share their experiences and outcomes using a novel preloaded DSAEK delivery system. During the webinar, participants will all remain muted, but please use the question and answer feature in Zoom to submit your questions to the panel after their presentations. As we all know, there's a growing popularity of EK procedures in the US, according to data published by the Eye Bank Association of America. And surely this trend is similar worldwide. The Lion's Eye Institute for Transplant and Research, known by many by the acronym LEITR, has led the way in introducing preloaded DSAEK and DMEK corneas beginning in 2012, when we were the first eye bank to offer a preloaded DSAEK graft in the endoglide. Since that time, we have introduced our own LEITR modified preloaded DMEK delivery system and have distributed well over 2,500 preloaded corneas. Although DMEK has been widely adopted, DSAEK procedures continue to outnumber DMEK procedures in the US. Because of this, we sought to design and preload a DSAEK delivery system that would ease DSAEK transplant procedures while promoting improved clinical outcomes. Just less than a year ago, we introduced the LEITR TransplantREADY DSAEK 3.0, a preloaded DSAEK delivery system. Prior to launching this new DSAEK delivery system, we performed various studies associated with tissue orientation in the delivery device, stability through preservation and transport, and endothelial cell damage through delivery into an artificial anterior chamber. We also compared endothelial damage using the DSAEK 3.0 to other DSAEK implant techniques to include the boost and glide and the forceps technique. The results of these studies document we've achieved our objective of easing the DSAEK transplant procedure while promoting the potential for improved clinical outcomes through significantly less cell damage. We'll publish these studies and are happy to present them to you in another forum. This webinar is focused on the clinical experience of our 3 surgeon panelists using the LEITR DSAEK 3.0. As we transition to their clinical experience, I'll end my introductory comments by sharing that we have distributed 237 preloaded DSAEK grafts in the DSAEK 3.0 for transplant, 233 domestically with an average storage time of 24 hours, and 4 internationally with an average storage time of 108 hours. 50 different surgeons have used the device, and the graft specs have an average diameter of 8 millimeters and an average thickness of 64 microns. The average incision size being reported is 3.4 millimeters, using 1 to 2 sutures to close the incision. Our agenda for this webinar will have Dr. Stephen Kane present on the development of LEITR's DSAEK 3.0 delivery system. He'll present a surgical video and case study and share tips and tricks for using the DSAEK 3.0 delivery system. Dr. Yassine Daoud will present a very challenging transplant on a patient with ICE syndrome. and Dr. Bert Knauf, having the largest number of implants using the DSAEK 3.0, will present his surgical experience, his surgical technique, and a case study. After each surgeon has presented, we'll bring them all back online for a Q&A session again. Please submit your questions in the Zoom application. So let's get started with introductions. Dr. Bert Knauf is the president and CEO of Eyesight of Tampa Bay. He's chief of ophthalmology at the Morton Plant Hospital. He's clinical assistant professor at the University of South Florida College of Medicine, where he has taught since 1997. He did his cornea fellowship at the University of South Florida and his ophthalmology residency and internship at University of Texas Southwestern in Dallas, and earned his medical degree at University of Florida College of Medicine. Dr. Yassine Daoud is the associate professor of ophthalmology at Wilmer Eye Institute at Johns Hopkins University. He's chair of ophthalmology at Howard County General Hospital. He did his cornea fellowship at Wilmer Eye Institute and his ophthalmology residency at Duke University Eye Center. He did an internship at Johns Hopkins Hospital and a clinical research fellowship at Massachusetts Eye and Ear Infirmary, and earned his medical degree at Harvard Medical School. And Dr. Stephen Kane is the founder of Tailored Eyes in Venice, Florida. He's a clinical advisor and faculty instructor for the Lions Eye Institute for Transplant and Research. He did his cornea fellowship at University of Pittsburgh and his residency at University of Florida. He also did an internship in internal medicine at University of Florida and earned his medical degree from Jefferson Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania. I'll now turn this over to Dr. Stephen Kane as our first presenter.
Thank you for the introductions, and thank you to everyone. It's a privilege to be here this evening. My name is Dr. Kane, and I am proud to be the co-creator of the DSAEK 3.0 with Dr. Eric Abduliev. And let's get right to it. So I wanted to start by talking about the origins of the 3.0 and sort of why we even did this. I think we all know that today with the development of DSAEK surgery has been largely reserved now for the sick eyes, the challenging eyes, eyes that you can't do DMEK in. And the thing that was most frustrating for me is we're taking the eyes that are the sickest and making the largest wounds in them. Most of the insertion devices are well over 4 millimeters. I think most people would say the endoserter needs pretty close to 4 millimeters, although I've seen people stuff it through a 3.8. I think that just having a large wound contributes to difficulty maintaining and controlling the chamber, which can lead to chamber collapse. Some people get around that by using an AC maintainer, but you're not always doing surgery in a facility that has an AC maintainer, and it's additional equipment to know how to utilize. And one form of the AC maintainer was recently pulled off the market. I hope they bring that one back at some point, but the traditional Lewicki one is known for leaking through the paracentesis. And all that aside, you're also talking about I like to say you're either folding it and crushing it, or pushing it and squeezing it, or pulling it and squeezing it through the wound. So there's a lot of manipulation of this delicate tissue with high propensity for cell loss. And I won't steal too much thunder. There are probably some publications coming in the near future with this, but traditional forceps alone, you can have about 25% cell loss just from the delivery itself. And so if we're talking about an already sick eye, challenge maintaining the chamber, large wound, lots of sutures. As we all know, suturing an edematous cornea can be like suturing a soft sponge. It can be challenging. So I really wanted to find a way to minimize the wound size, minimize tissue damage, and promote chamber stability. And so this was actually born on a flight to teach cornea transplant down in Mexico with Dr. Eric. Dr. Abduliev and I were sitting next to each other, and we sort of brainstormed for a few hours. And the beauty of this technique is that all of the tissue transfer from outside of the eye to inside of the eye passes through a glass tunnel. The injector itself is exhibiting no force, no stress on the tissue, and the stress of maintaining the wound open is actually put around the glass injector. So it's really a touch-free delivery system. And the concept was to use fluidics just like we do for DMEK tissue. And, you know, a few years ago, this probably wouldn't have been very possible because we were still using pretty thick DSAEK tissue. So the advent of the ability, which Dr. Abduliev again has pioneered, the ability to cut thinner and thinner tissue, and now consistently can do between 40 and 60 microns, what we would call nano-thin tissue, that really allows for delivery through a much smaller wound, and the mechanics where now you can push the tissue through with fluid. So the DSAEK 3.0 is currently the world's smallest DSAEK delivery system. And if you use a keratome, as we've learned, you can get through a 3.2 millimeter incision with this, which is very small. 1 or 2 sutures is all you need to close that. And it's very helpful for maintaining the chamber. The other benefit is because the system is closed, so there's no open wound. Once you slide the injector into the main wound, it's a closed system. And so by adding fluid to a closed system, you can deepen the chamber, which will spontaneously allow the tissue to open. Or if you wanted to shallow the chamber, you could push down on the wound or push down on a paracentesis and shallow chamber, just like we do for DMEK. So it really allows for total control of the anterior chamber in what's otherwise a sick eye. And again, as I mentioned, because we're using thinner and thinner tissue, and right now we're at about 40 to 60 microns through this device, you really get more DMEK-like results, which is fantastic for these patients. So here's a video, and I may ask you to pause it, Art. This, before you start, if you could just pause it for 1 moment. This is actually my first live patient. This was a patient who traveled from Mexico, and this was someone who had multiple surgeries previously, had the lens was actually sewn in the eye to the sclera. I believe like Ahmed did that surgery in Canada, and the patient had really good vision. However, over the last few years, it slowly deteriorated. And you can see based on this photo, it's a very edematous cornea. Actually, the view inside the eye was quite hazy. While I was tempted to do a DMEK, if you look in between 2 of the corneal marks there, you'll see some suture tails. And I was actually worried that those suture tails were going to hang up the DMEK tissue and make it challenging to unfold, because he also did a pupilloplasty at the same time as suturing the lens in. Beautifully executed work, just made me a little nervous about either vitreous coming forward or getting my DMEK tissue hung up on those suture tails. So you can play the video, please. So I measured with calipers the incision size. There are a lot of, since this was the first live case that I did, there are a lot of mistakes or things that I've improved on since then, which we'll talk about. But I kept the wound at a small size while I strip under a cohesive viscoelastic. All this is pretty standard for people who currently do DSAEK tissue, you know, gentle stripping, trying not to disturb the stroma too much. Here I wanted to make sure that the tissue is free from the glass injector. I was trying to push the tissue in this video, which we've learned subsequently actually pulling the tissue is more effective. Here I'm enlarging the wound to get it to that 3.2 millimeter size. And notice in this video, we're going to go in bevel up. I actually think now it's a little easier to go in bevel down and then rotate to bevel up. But you can see the chamber's already deepening, the tissue's in, and it instantly unfolds because the chamber's deep. I like to place some sutures usually before centering the tissue, but I'll you know, of course, put a little air bubble underneath to elevate the tissue off the iris. And then I suture the wound. You do 10 minutes of a full air fill, and then I do a partial fluid exchange. And so the conclusion of this is just like you would conclude any other DSAEK technique. The benefit is, again, like there was no, from the processing of the tissue till the tissue is inside the eye, there's no touch. So there's no additional cell loss that the surgeon has contributed by the method of delivery. We can go forward to the next slide. And so this is that exact patient at post-op week 1. And to my amazement, he was 20/25. And I don't know how many of the panelists have had this experience. In my experience, this was the first patient that I have ever done DSEK surgery on who was 2025 at post-op week 1. That's not uncommon for DMEK. I've had many DMEK patients who were 2020 or 2025 at post-op week 1. That was a first for me to have a patient 2025 at post-op week 1 after a DSEK. You can see how clear the tissue is. It was just fantastic. This patient was very happy with the results. And this next case, I wanted to showcase, I don't have the video for this finished. This was a recent case. I did this a week or two ago. This patient has a very ectatic, warped PKP. You can almost see the cornea protruding out at you from the screen, how the front of the cornea is actually out of focus compared to the limbus here. That's how far forward it was. I believe the patient, because of the cornea, was about a minus 20 something. And this graft had been done 30 years ago. His host tissue was so thin, it was about 70% thin in many areas. And I knew that this would be really challenging if I had to make a large wound. So this was sort of a perfect example of a patient who really would benefit from a DSEK. There was no chance of shallowing this eye enough to unfold a DMEK graft. Even with a flat chamber, the cornea would remain completely domed over the eye because of the amount of keratoconus this patient had. And the surgery went very well because you can appreciate the poor quality of his host cornea by needing 2 sutures through the paracenteses to close them. That's how difficult his host tissue was to work with. And here's his post-op day 1 and his post-op week 1 on the right. I want to highlight at the post-op day 1, there's a little bit of haze to the graft, and that's actually just some edema in the stroma, the small amount of stroma. I believe this was a 60 micron graft. And you do have some swelling in the stroma of the graft. However, that's not a marker of the function of the endothelium. And as you can see, it's crystal clear at the 1 week mark. I think if someone had delivered this by forceps or some other method and the tissue wasn't bathed in fluid and you had that level of haze, that might be something people would be concerned about. However, with this technique, it's actually normal to get a little bit of that haze just from that edema, but the cells pump that out right away. So some tricks and things that we've learned since we first started doing this, as I mentioned, it is very helpful to mobilize the tissue in the tube before going to inject it in the eye. And with a reverse Sinskey hook, if you just slightly pull it, you'll get a little bit of movement, and that's all you need just to verify that the tissue is actually mobile. Instead of enlarging the wound by cutting sideways, which I did in this video, you actually get much better wound creation and a much easier time inserting the injector if you just use a 3.2 millimeter keratome. Most manufacturers have one readily off the shelf, and maybe 3.2 plus, maybe just slightly larger if you need to. But my theory on this at the moment is that if you make a biplanar tunneled wound into the cornea, and then you go in and you cut sideways, you could actually create a little bit of an internal edge in the middle of that, which could hang up the injector. So I think that Dr. Abduliev was the one who suggested this, and he's absolutely right. It is much easier if you just use a 3.2 millimeter keratome, if you're doing a DSEK alone, then make your main wound straight away with that. If you're going to do a phaco DSEK combo, use your preferred size of the keratome to make your wound, do your phaco, and then when you enlarge it with a 3.2 keratome. For DMEK, I use a 3 cc syringe. However, for this technique, I recommend a 5 cc syringe. You do need a little bit more fluid to push the tissue out through the injector, so a 5 cc syringe does give a little better fluidics. I don't recommend flushing the Optisol GS. I think it just adds to a level of possible error by the surgeon where you could incidentally eject the tissue into the BSS before it makes it into the eye, and that just now you're back to doing a traditional technique. Reloading it not by the eye bank is not recommended, so I do not recommend flushing. I haven't actually flushed my DMEK or my DSEK tissue now for several years, and it's a step that doesn't have to happen. as I mentioned, I think it's a little easier to go in the eye if you insert bevel down and then rotate up once inside the eye. And in terms of chamber depth, this is sort of the opposite of DMEK. So in DMEK, once the tissue's in the eye, we want to shallow the eye right away to start promoting scroll unfolding and to reduce the risk of tissue extrusion. In this case, having a little bit of a deeper chamber is actually beneficial. You'll get spontaneous graft unfolding. And that's really the beauty of this system, because it's a closed system. Once you get the tissue in the eye, if you give a little tiny extra bit of fluid, doesn't have to be a vigorous pulse. It can just be a gentle addition of fluid, and you'll deepen the chamber and the graft will unfold. In the case that the second case that I showed, I actually inadvertently flipped the tissue by catching it on the inside of his PKP graft. What I should have done is just redirected my cannula and injected a little deeper into his plenty deep AC. However, I didn't do that, and I ended up somersaulting the graft. And an easy solution to this is if you take a cannula with BSS in one hand and you go in one paracentesis that way, and you go in your other paracentesis with an iris spatula or a Drysdale, any whatever instrument you'd like to use. And you can use the cannula with BSS to keep the chamber deep while you're doing this, and just using a two-handed technique, sort of somersault the tissue on top of itself to rotate it and get it into the correct orientation. And that concludes my tips and tricks. I really appreciate everyone's time this evening, and thank you.
Dr. Daoud, if you can unmute, and we'll get started with yours presentation.
Dr. Kane, that was a fantastic presentation, and thank you so much for the detail. And I think there are tremendous pearls that actually Dr. Kane has introduced to us, and I think it was really wonderful for all of us to listen to his beautiful educational techniques, as well as just really things to get you out of trouble. And I think we're all very grateful for you. So thank you so much for bringing and helping bring this technology. Before I start the video, in all of my endothelial keratoplasties, I'm almost exclusively a DMEK surgeon, except in very complex cases. So when Art and Karen approached me, I was like, well, I only do DSAEK in the super complex eyes. That's the only time that I actually by now do DSAEK. And I'm a strong believer in DSAEK. It took me actually forever to transition to DMEK because I was so happy with it. The truth of the matter is the CPTS study, the cornea preservation time study, showed that no technique is better than the other in regard to endothelial cell loss as a primary, like when it's prepared by the surgeon and then, injected, whether it is pull, push, needle, needle or suture, pull through, or Busin glide or tannin glide, whatever you want to name it, they all are pretty much equivalent. I was actually the PI, API of the multi-center study on that. And then, this thing comes in and I'm like, what is this new thing that you guys are trying to, to bring forward? And it took them a little bit to convince me. And I was like, you know what? I have a lot of fellows that I train every year, and anything that reduces, my speed of getting gray hair would be very beneficial. So less touches, less movements, less instruments in the eyes is always a wonderful thing. And I am a strong believer that less is more. The eyes are not meant to be touched too much or manipulated too much. Therefore, the least possible amount of manipulation is the best for any eye. And I've done quite a few hundreds of transplants. And I have to say that DSAEK 3.0 has been incredibly helpful in my practice. So this is one of the nightmare cases that, of course, I have, just to show you that, yes, you can use this as one-handed, but sometimes you can still use the traditional ways of doing it while you're transitioning as well. This surgery is done by me, not by my fellow. Because this is a patient who I believe monocular that I did about a month ago with ICE syndrome, iridocorneal endothelial disease. Can we please start the video? You can see that the patient has had really she's had glaucoma surgeries. She had horrible corneal edema that I had to actually clean her her epithelium. You can see the severe essential iris atrophy, even and a significant synechia. The IOL is really coming forward. I'm trying to liberate some of the iris synechiae so that at least I have an entry point for this patient, for this very difficult eye. Again, I strip under Helan and I remove the patient's endothelium and decimase. This is just like a syringe, really. It just comes preloaded. It's perfect. I still like to exchange it because I feel that if you actually exchange it, it has a little bit better attachment rates. When I used to do DSEKs, I was so spoiled that I almost rarely brought the patient back. This is what Dr. Steve was telling us, that you need to pull sometimes you need to pull the tissue forward a little bit. You can see I'm trying to actually get into this 3.2 millimeter, but the eye is so shallow and there's posterior pressure, severe synechiae, that I cannot actually do this in a one-handed technique, that I have to deepen the chamber to help me just to even get in. Look how much I'm almost touching the eye wall and pushing it, even though I am actually pointing way up towards the cornea. So I always teach my fellows, point towards the cornea, not towards the eye wall or the iris. The cornea, you are replacing it. The iris or the lens, you do not want to really touch. And then I rotate because it's easier to actually rotate inside the eye. It's easier to go bevel down. One small trick here is I remove the Lewicki because I don't need it anymore. You see that with my second hand, I actually put the paracentesis. If you actually push down on the paracentesis, it creates a path of least resistance. So your AC is not super inflated, and that allows the tissue to be delivered pretty easily. As I am coming out, you can see that I'm really struggling to keep my AC, and the tissue still wants to come out. So just putting a little bit of pressure on the wound can be very helpful. Can we pause the video for now for a second? So with these incredibly difficult eyes, one thing that you have to do is you have to see, how can I continue keeping the, the anterior chamber? Should I not? Should I use a Lewicki or not? With the DSAEK 3.0, actually, I have done quite a few, but this is the only time that I probably actually two. This is one of the 2 times that I needed a Lewicki or anterior chamber maintainer because the eye is so sick, and I needed all the help that I could get so that I don't squash the tissue, that that the lens is not going to come and really destroy my endothelial cells. So don't be shy to go back to your previous techniques, even with this DSAEK 3.0. This actually really, it lends itself incredibly well to all other techniques that you have. At some points when my fellows are doing it, you can even reach across to help the tissue come forward if you want to. So you could use a lot of this. When you're actually injecting, Steve said, a 5 cc is better, and I do agree. A few times, especially in the hands of a beginning surgeon, 3 cc's, you actually run out of the BSS without the tissue there. You have to take it out, you have to refill, and then bring it back in. So it's much better to have a little bit more BSS than you think that you may need. The other thing is, try to liberate the tissue right as you're coming in because it's usually, it's shipped, it may be stuck to the glass, so it's really good idea for you to mobilize it. And the third pearl is push on the paracentesis with one hand and just inject with the other hand with just a small bursts. You do not need to go all through. All you need is just a little bit of gentle waves. Once the tissue is in, then all techniques are really become the same after a while. Can we continue with the video, please? This is actually, so now you see that I'm even having a hard time once the tissue is in for me to even bring it out because the synechiae are preventing the tissue from folding. And this is a LASIK roller that I usually routinely use for pretty much most of my DSAEKs, just to basically even open the tissue, and then I remove my Lewicki. I always have to put a 10-0 with the Lewicki because I agree with Steve, it always leaks. This is actually anterior segment OCT that I have started using with my endothelial keratoplasties to show me, of course, in DMEK, it's incredibly helpful if you don't have an S stamp and whatnot. But for DSAEK, it shows you if there are any pockets. One thing that I was worried about in this patient, of course, you can see that the green line is the horizontal, and the blue line is the vertical. And I'm actually going across to see, do I have any hidden pockets? And I was very worried in that angle because you can actually almost see the iris at the end of the anterior segment OCT because the synechiae may be preventing your tissue from attaching. So you can see it in the bottom left in that screen. So anterior segment OCT is a fantastic new technology for DSAEK and DMAEK to really allow us to see where our tissue is in real time. In a nutshell, this has been a fantastic addition to our, to our techniques. I have to pass some surgeries to my fellows. The DSAEKs are the most complex, and honestly, I'm like, oh my gosh, it's a horrible case, and I have to give it to the fellow. And this has really made my teaching a lot easier, and I have to take less beta blockers in the morning. I'm happy to take any of your questions at the end. Dr. Knauf, the floor is yours.
Dr. Knauf, if you can take yourself off mute, we'll get started with your presentation. Thank you so much, Dr. Daoud.
Thank you, Art, and thanks to Dr. Daoud and Dr. Kane. I'll probably be saying some of the same things that you've heard so far. This is actually the first consecutive 19 cases that we did with the preloaded 3.0 DSAEK tissue from LEITR. Can you advance the slide? We took our first 19 patients. These, as mentioned by the other doctors, were all high-risk patients. I do DMAEK on everybody that I can do it on. There are a lot of patients who aren't ideal DMAEK candidates. So those patients who have prior vitrectomies where you can't shallow their anterior chamber, even though I've done it in a few, but some patients you don't really want to have that adventure with. Glaucoma surgery, patients with tubes and trabs, patients who have advanced glaucoma. You know, sometimes I've had cases where you put the air bubble or the gas bubble up there and their pressure's high because it's blocking their ostium. And I'm a little reluctant to do that on patients who have really advanced glaucoma and prior glaucoma surgeries. Failed PKP grafts, those can be a challenge to get the DMAEK tissue in the right spot. And so I think the DSAEK tissue is good, and especially with the thinner levels that we're getting with these anterior chamber lenses. That's, for me, I'm not brave enough to do DMAEK in anterior chamber lens patients. And you know, patients who have really poor visualization and maybe a poor visual potential, and you're just trying to get them where their eyes healthy. They've had corneal ulcers and stuff like that, and you don't think that they're going to be like the 20/20 patient, but you want to get them to be a more healthy case, and those are good candidates. So all of the grafts were preloaded and prepared at the Lions Eye Institute for Transplant and Research. They were preloaded into a glass container. Average graft thickness was 63 microns, and almost all of them were 8 millimeters in diameter. I think I tend to size my failed PKP grafts a 0.5 millimeter smaller than the graft, so I can get it to be inside the graft. So probably a 7.5 here or there. And you know, the carrier is very similar to what we're used to with DMAEK grafts, so that's why it makes our lives a little easier. The surgical technique, I usually remove the transportation device from the jar with a curved hemostat. You can actually dump it into your BSS basin if you want to. I use also a 5 millimeter syringe filled with BSS. I do tend to remove some of the preservation media. I actually found it's easier for me to extract it rather than push it through. So I actually just very gently suck some of the tissue, suck some of the preservation media out without sucking the tissue out, of course. And I think that's a little easier and less stressful than trying to push it through. Then you remove the sponge from the tip. Examine it under the microscope, bevel up, use the Sinskey hook to advance the graft close to the tip. And I use a 3.2 millimeter keratome, and I enlarge it slightly. I go down, bevel down, and then rotate so it's bevel up so it'll be in the correct orientation. And then I use either air or gas. I do on occasion on these patients use 20% SF6 like we do in DMAEK, just because these are generally the more complicated patients. And I leave it there for 10 minutes intraoperatively, which I don't do on my DMAEK grafts anymore. And then I put as many sutures as it takes, usually 1 or 2, but occasionally I'll put 3 stitches in. I mean, the bottom line is these are complicated patients, and you don't want to make your postoperative course any more difficult. So the results on our 19 consecutive patients, the grafts unfolded in the correct orientation in 100% of the patients. We had success in 18 of the 19 cases. The grafts were clear and attached. The one patient that was a failure, he was the trifecta. He had a prior tube shunt, a failed PKP, and an anterior chamber lens, and he was monocular. And so unfortunately, he didn't have any air bubble in his anterior chamber on the first day. And so the graft was unattached, and I repositioned it in the office and rebubbled it. And he was really upset when he was walking out because he couldn't see because his eye was full of air. And so he came back the next day, and there was still no air in his anterior chamber, and it wasn't attached. And so he refused a second rebubbling. So we ended up just going ahead and doing a repeat PKP. So in our results, pretty high rebubble rate, 6 out of 19, so 32%. But I don't believe that it has anything to do with the tissue. I believe it has to do with the complicated patients. It's the patient selection. So these are all those sicker eyes that we don't want to do DMEK on. But when I rebubbled them at the slit lamp, like I said, except for one, all of them were successful. We can talk about if anyone has any questions, but I rebubble at the slit lamp. And then I lay them back for about 10 or 15 minutes in the office, and then I just set them up and make sure the bubble's not is the appropriate size when they go home. So in conclusion, this is a novel delivery system with preloaded DSAEK grafts. It saves OR time. You can use a smaller incision. It's much similar to our preloaded DMEK grafts, and it can be used in patients not considered ideal DMEK candidates. So I was asked to present a case study, and this was one of our veterans, Iraq war veteran, 38 years old. He was injured by an IED in 2004. He had traumatic cataracts removed at Walter Reed in 2004, and he had gradually developed corneal edema and band keratopathy due to iris capture of his lens with contact with the superior cornea. His vision was 2250. So the first thing I did was an IOL exchange with a vitrectomy. I put in a sulcus PCIOL and did a pupilloplasty in January of 2019. And postoperatively, he did pretty well at first. He was almost 2050 plus 2. He was almost 2040. But then ultimately his corneal edema worsened and his vision dropped to 2400. So we decided that he was a good candidate for the DSAEK 3.0. We did that on September of 2020. Actually, interestingly, his insurance wouldn't pay for his tissue, and we were able to take advantage of the gratis program through LEITR. They actually donated the tissue, which was very generous, and the patient was extremely happy about that. Obviously, he wasn't that ideal DMEK candidate due to his prior vitrectomy and abnormal anterior segment. Postoperatively, he did well. His uncorrected vision was 20/70, about a month and a half out from the surgery, best corrected to 20/40. So then I removed his band keratopathy with potassium EDTA, and his uncorrected vision improved to 20/40 -2 and best corrected vision to 20/30 in March of this year. Thank you for your attention. Thank you for inviting me.
Very good.
Excellent.
I'm the only one that didn't unmute.
Excellent cases, guys. Really, Dr. Daoud, that's a very impressive, complex eye that you did a successful DSAEK in. And hearing you talk about handing over cases to your fellows, it wasn't that long ago. I guess I'm coming up on 4 or 5 years now that I was the fellow. And it was interesting because when I was at Pitt, I actually learned DMEK before I learned DSAEK, just because of the volume now. DMEK is much higher. And so to me, DMEK was the easier procedure. I didn't understand what the difficulty here was, because DSAEK is in all these difficult, challenging eyes that no one wants to operate in. But so I was laughing hearing you say that, because I completely agree. And fantastic case series there, Dr. Knauf.
Absolutely, you guys did a beautiful job, and I think these are fantastic cases. I have a fantastic fellow actually that was with me, and initially, I let her do 2 DMECs at that day, and she was like hoping she would do the DSEK, because you're right, she doesn't do much DSEK at all because we don't do very often. And then she's like, after she saw me with this case, she's like, I came in and I was disappointed that you are going to do the DSEK, but now I'm so glad that you did it. It's a tough case, but really, it's nowadays, I remember the early days of endothelial keratoplasties. I started doing them really in 2008 or so. It was a nightmare. I mean, and it took forever. And now with the Preloaded DSAEK 3.0, really it turns the surgery into 10, 15 minutes and air bubble. I mean, it's not a long surgery, but the beautiful thing is the AC is always contained, it's maintained, it's just, there's nothing that is going on. And since you can always put a little bit more BSS, and the beautiful thing is you don't have a, paracentesis, extra paracentesis or anterior chamber maintainer to also suture, which we know takes time, and just one more thing for for bacteria to come in and increase the risk of, so the less corneal incisions you have to create in any surgery, the better it is. No, absolutely. And to be honest, I think over the last 4 months, if I do a DSAEK, the DSAEK 3.0 has become my exclusive, actually, of doing things.
Yeah. Well, it's in some ways sort of like a vision or a dream come true to hear this. When you're going through developing something, you hope that you're on the right track, and my experience has been similar, and I've really enjoyed it, and hearing you say that really is very gratifying to me. I'm sure the LEITR team is happy to hear that too. I didn't do this in a vacuum. Obviously, this was with a huge amount of support. None of this would have happened without Dr. Abduliev and the fantastic team at LEITR. Obviously, I think I saw a question pop up about additional equipment, and I don't know how many surgeons are experienced with international transplant, but often it's they're unavailable or difficulty getting certain instruments that we take for granted here in the U.S. And yeah, that's one of the goals here with this, is it really minimizes the amount of equipment that you have to purchase, equipment you need. Honestly, you can do it with a keratome, a reverse Sinski, and some cannulas, and a needle driver to suture the wound closed. You really don't need much. And that's part of the goal here, that you don't have to buy punches to be cutting the tissue. No need for, sorry, Moria, but no need for the, blanking on it right now, the microkeratome to cut the tissue. This is kind of designed actually for, I don't want to say lower resource settings, but just places where they don't have access to all the things that we do in universities or in advanced surgery centers.
So I do have a question for the panel.
Can I pick up on Steve's point?
Yes.
In 2012, actually, I was invited to go to Mexico because they were giving up on DSAEK surgery because it wasn't working, and the tissue was incredibly valuable, and high detachment rates and whatnot. So I actually went with one of my colleagues, and we gathered 12 surgeons from across Mexico, and we spent a week with them and did live surgeries and whatnot. And to your point, I have been used to using the 10 Indoglide and I never thought about it. But then when they realized that the 10 Indoglide is 150 pop, and whatnot, they literally would go and unclip it and then take it out and then sterilize it and bring it back. Yeah. So we in the US, this is kind of, wherever I travel in the world, I'm always awakened by how privileged we are to an incredibly resource-rich area. And you go, I've done transplants in Saudi and in Lebanon, and I've operated in India, and I'm like, this is unbelievable. So you are right. The beautiful thing is you are not having tissue damage, by surgeons who don't do as many transplants as we do in the States. You don't have as many instruments and whatnot. So this is just one-stop shop. All you need is really a syringe and a keratome and a suture. I mean, not to make it sound like that easy, but really from resources standpoint, this really makes a big difference.
I would second that also. I've done about 150 corneal transplants in Honduras. and we have done pre-cut DSAEK grafts down there, where like we used to do with forceps and stuff, at about 2 weeks, almost 2 weeks out on the tissue, and the tissue definitely performs a little bit differently at that point than it does the way we're used to it. I'd be interested to know, if you put it in this preloaded device, I mean, would it still be good for up to 2 weeks? That would be interesting to see. I hope to get the opportunity to try that. So
I don't know about 2 weeks, but we've had 2 corneas that were prepared for domestic surgeons where the patient canceled, and we ended up sending these already preloaded DSAEKs into Mexico. One was transplanted after being preloaded for 4 days, and the other had been preloaded for 7 days. And the clinical outcomes that we're hearing from that surgeon are outstanding.
great.
I did have a question for the entire panel. The question was submitted about the thickness of the grafts. We at LEITR recommend really the nano thin, whatever you want to call it, super duper thin, 40 to 70 microns. The question is from a surgeon that currently uses about 100 micron DSAEK grafts. And the question is, what advice do you give for transitioning to this ultra thin DSAEK cut?
I don't really think that you need to worry about it. I mean, you're not having to handle the tissue. It's different if you're trying to pick it up with forceps and stick it in there. But since it's already preloaded and you inject it into the eye, it's going to act just like your normal DSAEK tissue that's 100 microns. I haven't found any difference in the way it acts inside the eye.
Yeah, I would second that and say that, if you're getting down into the PDEC thicknesses of 20 to 25, maybe 30 microns, that might behave a little differently. But from 40 to 70, it's really behaved very similar to 100. I completely agree. The only difference is in terms of if I wouldn't want to forceps delivery a 40 micron tissue, because it's going to be more crushed and more at risk of injury going through the wound. But this is, once it's in the eye, it behaves just like any other DSAEK tissue. It doesn't behave like a DMEK. It still behaves like a DSAEK.
Absolutely. And actually anything above the 25, you're right. It has been shown that PDEC almost behaves like a DSAEK anyway. So the 40 is a plenty tissue, and there's no age criteria like the DMEK and whatnot, because it's thick enough. And really, to be honest, I have always used, ultra thin. My preference is at the eye bank for the last 10 years has been the thinner, the better it is. In my experience, as a matter of fact, I think it unfolds the same, it attaches easier. That's the thinner it gets. But if you are a forceps delivery person, I totally agree. It is going to be rather messy because it folds in different ways. It doesn't fold the 40-60 that you're used to, and it doesn't handle as well. But if you're injecting or you're pulling through, like with any Endocerta or 10 Endoglide or DSAEK 3.0, it certainly should not be an issue, and it should behave just about the same, regardless of the thickness. Of course, a lot of the times that you are incorporating the tissue into some sort of device that is going to encapsulate and protect the tissue, the thinner the tissue, the less trauma it is going to be.
This question for Dr. Daoud. You mentioned placing a finger on the paracentesis while injecting the tissue. Is this to prevent fluid escape while you're injecting the graft?
I am so sorry. I must have misspoken. No, it's actually not your finger. I do place my finger on the wound, but that's for a different thing, which I'll come to in a second. If you are ever having, this is just a pearl in general for any of these endothelial keratoplasties, if you have a leak of air that you're having to do and you're pumping air into the eye and it is leaking, gentle pressure with your wound onto that, gentle pressure with your finger onto the wound, just holding it, not pushing it, will hold the wound steady until you are completely filled with air, and then the air surface tension will prevent the air coming out. All you need is for about 10 seconds, That's just a small pearl. If the wound, you have put 2 sutures, you really don't want to put another one, but it's still leaking, just hold it and it will work like magic. What I am talking about is exactly actually the opposite in here. What I am talking about is initially, and this you'll notice when you start actually doing the DSAEK, 3.0, I had a 5 cc's and I was rather aggressive actually in pushing, like you're pushing the BSS initially. And I wasn't thinking of just like gentle wave, like, just a little bit. And you push and the cornea becomes white because the pressure is so elevated. There's no escape with the BSS. The tissue is stuck in your DSAEK 3.0. It's not going anywhere because the pressure is so elevated inside of the anterior chamber in the eye in total. So what you do, your reverse Sinski or your 0.12 or something, just gently open your paracentesis away. And when you inject, the path of least resistance is the water has to come from your DSAEK 3.0 system through the anterior chamber, out through your paracentesis port. And you'll find that the tissue actually glides with that wave of water coming in. The moment it starts coming in, you can actually let go with your left hand, your non-dominant hand, your paracentesis hand, and then you can keep injecting. That will deepen it, and the tissue should open up beautifully like a flower.
Thank you. Dr. Knauf, you mentioned that you at times use SF6 with your DSAEKs. Is that your routine? And then a follow-up question will be for Dr. Daoud and Dr. Kane.
No, it's not my routine. I usually use air, but I don't know. I'm not sure which cases I do. I guess cases that I'm worried about that are like super complex and I kind of want the bubble to stay there a little bit longer. Like the case that Dr. Daoud presented, something like that. There's really not, if you can make a PI inferiorly, there's no disadvantage to having the bubble be in there longer, unless, like I said, I have had a couple of cases with advanced glaucoma, and then the pressure's elevated because the bubble's blocking the ostium or the, of their trabeculectomy or whatever. So I probably, that's why I'm probably not doing DMEK on some of those patients.
Dr. Daoud?
I don't use SF6 in DSAEKs, not because of anything. It just, I think that DSAEK is very forgiving. However, I totally agree that there's a definite room for SF6 with any that you're worrying about, that you're worried that, okay, you over manipulated the tissue or this and the tissue is not attaching. You need more air. You don't really, the patient is going to give you a hard time rebubbling in the clinic next day and whatnot. I think it's very reasonable. You just have to make sure that you mix it right in an isoexpansile, no more than 20%. As they say, experience is what you get when you get what you don't want. I was like, oh, the better concentration, the better, the higher the concentration, the better. And guess what happens 5 hours later? You'll be getting cold and the patient's pressure is 60. I think, as some of us, I like to admit my mistakes every once in a while. And then all of a sudden you have to go back, but no more than 20% for sure that you really should use. But I don't have any problems using it. When just a small pearl also, whenever I fill the eye and I'm worried about a patient with a glaucoma or something like that, or elevated pressure, I have relatively low threshold of giving the patient IV Diamox or oral Diamox in the postoperative, so that at least the pressure spike does not happen, afterwards. So I don't have to be called, or that I would have to snuff the nerve. You're not going to snuff the nerve overnight typically, but nonetheless, to be very safe in those patients, it's a very reasonable approach.
Dr. Kane, you use air?
Yeah, so to present, 3 panelists, 3 different ways of doing things. So I use air exclusively, in part because one of my colleagues had a wonderful experience with 100% SF6, which he had to burp the pressure for about a week. It kept every few hours for about a week. So yeah, I have gone to several different surgery centers at this point, and sometimes I'm in different places or facilities, and I don't always know who's how well trained the nurse may be who's handling the gas. I think air is the safest. I use air for DMEK. I use air for DSAEK. If I'm worried about the patient, I just see them back more frequently in clinic. So if I'm worried about a graft sticking, instead of seeing them at 1 day and 1 week, I might see them at 1 day and day 3 or day 4. And if I see some detachment that's forming, I'll be quick to rebubble it at the slit lamp. So I find air to be easy to use. I find it to be safe to use. And my rebubble rates have been fantastic with it. I don't feel a particular reason to use SF6, but I don't disagree at all. And you know, if you're not going to see the patient more frequently, using a gas that's going to hang around a lot longer is going to help you sleep better at night, for sure.
Obviously, you need to make sure that your surgery center is mixing it correctly. That's a given.
That's a given.
So I actually, since the 2 blocks that I have had with SF6, I mix it.
Yeah, right. Yeah, exactly.
That's the best way for you to know for a fact that you got 20%.
I just watch them when they do it, and I verbally confirm. Okay, so we have 1 cc of gas and 4 cc's of air. Okay, yes, correct. Okay, perfect. You know. So.
I think the next question is really for me, and that is, how far ahead do we prepare the tissue prior to surgery? Ideally, it's 24 hours or less. We prepare the tissue the day before surgery, but we have validated through our cell studies preparing the tissue and storing it up to 48 hours. And then I shared with you kind of the extreme, not in a cell study, but in a clinical outcome of 4 and 7 days preserved in the injector.
We might be surprised to learn that it lasts for a lot longer, just like those tissues that I took to Honduras, but after 14 days. We'll see.
Yeah. I have one other question. Oh, I'm sorry.
I'm sorry, the CPTS study, the cornea preservation time study, because, you know, again, in the United States, we are actually very picky at what tissue we get. And again, we're spoiled, let's just admit it. And a lot of the surgeons, after 1 week, they say, I don't want to have this tissue. And that's why the NIH funded that study. And it showed that there's no difference. But now you're putting it in, in a glass tube. I'm assuming if it's probably on the thinner side, even though it's going to swell up, because we know that it does swell up with the storage. If it's on the thinner side, I'm not sure it's going to make a difference. If it's on the thicker side, is it going to make a difference? I don't know. But if you're going to be shipping it, somewhere, or it's going to be longer, I would probably prefer using a thinner cut than a thicker cut.
Yeah, I agree with that, and I'll just add that we have looked at cell loss related to being in the injector, injecting it into a model eye. There will hopefully be some publications coming soon about some of this, but it's exceedingly low, less than 5%. And if you consider that your traditional forceps costs you about 1/4 of the cells, 25% or more of the cells of what you're injecting just from folding and pinching and stuffing it in, a 5% loss is negligible.
We're about 5 minutes after the hour, so I think we'll stop. I wanted to thank you, Dr. Knauf, Dr. Daoud, and Dr. Kane. I've really enjoyed your presentations and kind of the banter and answers to questions. Thank you so much for participating. And thank you, everyone who has joined us for this webinar. We'll be announcing the next one soon. Good night, or good morning, or have a great day. Thank you again.
Thank you.
Thanks for having us.
Thank you.
Bye, guys.
Bye-bye.